Hello, everyone. I think probably try to get started now. I think it's 9 o'clock, so at least try to get things started on schedule and hope we can stay that way. I'd like to welcome everyone for coming. Oh, you can. Folks can't hear me in the back. Can you hear me better now? Okay, I'll try to stay close. Well, thank you all for coming. It's great to see everyone here. Welcome to the Breast Cancer Conference. I'll be speaking this morning about predictors of recurrence after a DCIS diagnosis. My name is Brian Sprague. I'm an assistant professor in the Department of Surgery at the University of Vermont and a member of the Vermont Cancer Center. I'm supposed to start with a disclosure statement. I don't have any financial interests in this material. I do also like to point out, though, kind of some of where I'm coming from in this. I'm not a clinician. I don't treat patients with breast cancer. I'm a cancer epidemiologist, so I study patterns in data amongst large groups of patients. So just kind of keep that in mind. I certainly recognize that each patient is unique and the treatment decisions made for that patient by the provider and the patient just consider so many different circumstances. And I'll be kind of giving more of a broader overview of just what we see kind of more at a larger population level amongst women with DCIS. I'd also like folks to feel free to interrupt me at any time if I start getting too quiet or you have any questions about any of the information I'll be showing, because I really want to, I'm here to convey information to you, and I want to do that as clearly as possible and tell you the things that you're interested in hearing about. So here's an overview of my presentation. First, I'll just give some background about DCIS and why I think it's an important public health problem. And then I'll talk about recurrence after DCIS, including just general statistics on the risk of a recurrence after a DCIS diagnosis, and then looking at what we know about predictors of risk of recurrence after DCIS. And then I'll talk about some research that's currently ongoing and some future research we have planned here in regards to DCIS. So here's kind of the basic background slide on what DCIS is. So this is the earliest form of breast cancer, often called stage 0 or non-invasive breast cancer. And you can see kind of in this figure here showing the normal duct of the breast here, where the cells are just nicely aligned and as a normal duct with a clear lumen in the middle. And then DCIS, we have this proliferation of cells with a abnormal phenotype. So they look unusual, they look malignant, but they're still confined within the ducts of the breast. And then we have invasive breast cancer, where they start to spread outside of the ducts of the breast. So that's kind of the key distinction between DCIS and invasive breast cancer. The incidence of DCIS in the United States has really risen dramatically over the past 30 years. This is national data from the SEER cancer registries. And you can see, so incidence is the number of women diagnosed with DCIS per 100,000 women in the United States. And you can see that back in 1980, it was around 3 or 4 per 100,000 women per year. And then it really rose rapidly through the 80s and 90s, and now in 2010, it's up around 30 per 100,000 per year. And I'll talk a little bit about why this has happened. Question?
Recurrence, or is that due to reporting?
That's a good question, and we'll get to that. Another question.
On that chart that you showed, is there another chart of age that shows at what age this occurs?
At what age?
Yes.
Okay, I don't have a chart on that, so I'll tell you. It's more frequent among older women, but it kind of, like invasive breast cancer, increases kind of steadily and slowly at early ages through 30s and 40s, but is much higher amongst women in their 60s and early 70s. So some more statistics just in general. Every year, about 50,000 women in the United States are diagnosed with DCIS. There's now about 500,000 women in the US who are living with a DCIS diagnosis. And we project that by 2017, there will be over 1 million women living after a DCIS diagnosis. So these are kind of the consequences of this rising incidence that I showed in that last slide. So the question is, what's going on here? And a real let's see. Most of the answer is screening mammography. So 85% of DCIS cases are detected by screening mammography, as opposed to arising via a patient feeling a lump and reporting clinical symptoms. Really, the vast majority of these are picked up in women who have no symptoms at all, who don't feel anything, but rather something is seen on the mammogram that shows evidence for DCIS. And really, this is the goal of screening mammography, is to detect early stage breast cancers instead of letting them progress to a later stage where they would arise clinically. With the whole idea being that detecting them at an early stage at diagnosis leads to higher survival rates. These are, again, national data on 10-year survival rates according to the stage of diagnosis for breast cancer. So we have in situ, which includes the DCIS lesions, and the 10-year survival rate is nearly 100%. It's 99.9%. Whereas for localized invasive breast cancer, we see a drop in the 10-year survival rate, but still very relatively high, and then much lower survival rates for regional and distant stage breast cancers. So the idea with screening mammography is to catch more of the cancers up here where they can be successfully treated. And this is national data on the percent of women screened within the past 2 years. This is from the National Health Interview Survey. And as I'm sure most of you are familiar with, screening really started to ramp up in the 1980s. By about 1987, 30% of women aged 40 and older had been screened within the past 2 years, and that steadily climbed through the 80s and 90s, and now is up around 70%, and has been for a while. And if you just kind of overlay that trend with the trend in DCIS that I showed earlier, so now here that blue line is still showing screening, and the red line is showing the incidence of DCIS, you can see that they track very closely with one another. So really, it's not like we've had some outbreak of new risk factor or anything like that. It's more that we're using screening mammography more intensely, and so we're picking up more of these early stage cancers. And just to kind of illustrate this further, this shows the percent of breast cancers that were diagnosed at an invasive stage back in 1975. It was 97% versus 3% DCIS. And the proportion that are DCIS have just grown steadily over time, and now it's up around 20% in 2010. And the results of this early detection of breast cancer has been a decrease in the breast cancer mortality rate. So here's that screening line again, and then now I put breast cancer mortality on the same chart, and you can see that it was pretty steady really until we started ramping up screening in the 80s and 90s, and as a result, breast cancer mortality has been declining fairly substantially since the early 1990s. And we know a lot of this is due to screening. We also know a lot of this is due to advances in treatments for breast cancer, certainly the development of new adjuvant therapies, and even better breast cancer surgery practices, the development of tamoxifen. So a lot of things going on, and there's been a lot of folks who have evaluated these trends and kind of concluded that screening and treatment have both kind of equally contributed to this decline in breast cancer mortality. So these are all kind of, I guess, the good news slides. On the flip side, thinking about DCIS, okay, survival is very high, but we do know that women with DCIS have a fourfold increased risk of developing invasive breast cancer after their DCIS diagnosis, even when they've been treated with essentially standard treatment approaches. We also know that treatments for DCIS do have side effects. So despite the fact that women have very high survival rates after a DCIS diagnosis, the impact on their lives is still very substantial. And this kind of generates a number of research questions that folks are trying to address. Some of these are, what factors are associated with the risk of recurrence and progression to invasive cancer? So can we reduce this increased risk of developing invasive breast cancer? Along the same lines, what can be done to reduce the risk of recurrence? And can we identify DCIS cancers that don't need to be aggressively treated? So we know we're diagnosing a lot of these early stage breast cancers, and there's various pieces of evidence suggesting that we're probably we have such sensitive screening and imaging techniques now that we're diagnosing cancers that probably are super slow growing and may not actually harm the life of a woman during her lifetime if they were not picked up by mammography. So we know some of that is going on, but we also know that some of these DCIS cancers are dangerous and do lead to invasive cancer and need to be treated aggressively. So a real question in the field now is, can we kind of sort this out and find cases that are not those aggressive cancers that may be able to be spared more aggressive treatments and not have to go through the side effects of all these treatments. Okay, so now I'll try to talk about some statistics on recurrence after DCIS. And before coming to the University of Vermont, I was at the University of Wisconsin and got involved in this fairly large cohort study of DCIS cancers. This was a population-based study, so I'm trying to present some data that really reflects the experience of women in the community diagnosed with DCIS. This is not data from a randomized trial. So one thing to keep in mind is randomized trials offer benefits in being able to really compare specific treatments in very controlled populations, often where everything's performed at academic medical centers or specific institutions. And that can give us very good information on the effectiveness of a certain treatment. But then it's also interesting to look at what happens in the community when these practices are used, not just at the academic medical center, but just all over your state or all over the country by all kinds of providers under much less controlled circumstances, to really get a sense of what's really happening out there in the population. What are women with DCIS actually experiencing in terms of recurrence rates outside of what's happening in very controlled clinical trials. So this is an example of this type of study where there's a statewide cancer registry in Wisconsin, and women were identified who were diagnosed with DCIS between 1995 and 2006 and invited to participate in this cohort study where they would be, there were interviews with the patients as they were enrolled in the study. So typically about 1 year after they were diagnosed, they were contacted and invited to participate. And then every 2 years after that initial interview, they'd be re-interviewed to ask about any recurrences that occurred and to update information on their treatments received. And I'll talk a little bit about some of the health-related behaviors and side effects of the treatments that they were experiencing. So this is kind of the basic plot of the risk of recurrence after DCIS experienced in this cohort of Wisconsin women. There were about 2,000 women in the cohort at enrollment, and this shows the probability of recurrence according to the years of follow-up. So you might look at 5 years of follow-up, about 6% had experienced any type of recurrence. And here when I say recurrence, I'm using this to mean any breast cancer diagnosis after their initial DCIS diagnosis. So this could be in the same breast or in the opposite breast. It could be an invasive breast cancer diagnosis or another DCIS diagnosis. And really that's done by necessity because it's so hard to determine, is a new event really a recurrence from that initial DCIS or is it a brand new cancer? And folks, the pathologists can argue forever about that. But, I think what's very relevant is, what are the chances that you're going to have another breast cancer event diagnosed? And this line is kind of a straight line, and it's about 1% per year, roughly, a little more than 1% per year. So you can see at 5 years, it's just above 5, maybe 6%. 10, it's getting up to about 12% have had a recurrence by 10 years. So just a fairly linear progression there. Now, looking at the types of recurrences that occur, it's kind of split 50-50 for both of these. About 52% were another in situ diagnosis, 48% were an invasive cancer diagnosis, and 52% were in the same breast, 48% were in the opposite breast. So kind of a wide variety of outcomes, each of which was pretty much equally likely. And here again are just some other ways of looking at these numbers. So these are the 5-year probabilities of having one of these events. So you can see it was 5.5% for any second breast cancer diagnosis, 3% for an ipsilateral diagnosis, so that being in the same breast, 2% in the opposite breast, and 2.4% chance for an invasive breast cancer diagnosis at 5 years. So those are kind of the average numbers for the entire cohort of 2,000 women, and now I'm going to break it down by the types of treatment that they received. This shows the distribution of treatments within the cohort. You can see the most common treatment was breast-conserving surgery or a lumpectomy with radiation added to that. So that was about almost half of the population received that kind of treatment. A smaller percent, 10%, just had breast-conserving surgery with no radiation. A fairly substantial fraction had an ipsilateral mastectomy, so about a third of the patients. 5% had a bilateral mastectomy, and then there was a very small group, 3%, which had no treatment beyond a biopsy. And so this slide, if you're not familiar with DCIS, can kind of give you a sense of the spectrum of treatments that women are receiving for this diagnosis. You know, it really varies from almost nothing all the way to bilateral mastectomy, and we see a fair amount in almost all of these categories. I also wanted to add that about 38% took tamoxifen in addition to one of their treatments. And this number is probably on the low side compared to current treatment patterns for DCIS. This cohort was recruited in 1996 to 2006. So especially on that early side in the late 1990s, tamoxifen was pretty unusual. But is more commonly used now. Here are the probabilities of a recurrence by year 5 according to the treatment that was received. It was highest among women kind of least aggressively treated. This is the breast-conserving surgery group, where about 13% had a recurrence by year 5. And that was with no radiation added. When radiation was added, the risk of recurrence was markedly reduced down to about 5%, very similar to what was experienced for ipsilateral mastectomies. And then the bilateral mastectomy group had no recurrences that occurred. Here I've shown the reduction in risk when tamoxifen was added to any of these treatments. So in general, we observed that tamoxifen reduced the risk of recurrence by about 25%. This graph kind of gives you a sense of the absolute impact of adding tamoxifen to any of these treatments. You can see it kind of brings it down proportionally depending on what the risk of recurrence was in each of those groups. Something that we've kind of highlighted is this comparison between the breast-conserving surgery plus radiation group and the ipsilateral mastectomy group. There's been a lot of research in the past in invasive breast cancer about the effectiveness of breast-conserving surgery, but there's never been a randomized trial of breast-conserving surgery versus mastectomy amongst DCIS patients. So it was kind of reassuring to see in a population-based cohort that women treated with breast-conserving surgery for DCIS had close to equivalent outcomes as women with an ipsilateral mastectomy. So indicating that, yes, breast-conserving surgery plus radiation is a very effective treatment strategy in DCIS. Yes?
You talk about tamoxifen, but some treatment involves Venera.
So other hormonal agents? Yeah, this is true. So I focused here on tamoxifen because that was far and away the most common used in this study, which again went through 2006 for the initial diagnoses. So there were other treatments reported, but with very low numbers in this cohort that really made it impossible to produce any valid statistics. You know, if we had 10 women using that treatment versus 100 in these other groups. Yes?
I thought tamoxifen was used for women who are still menstruated as opposed to postmenopausal women.
Yeah, there's, I think that's...
Because I'm on a different one, Incidence, which is they didn't give me because I'm past menstruation.
Yeah, so now I think in particular using aromatase inhibitors and and raloxifene is another option. Did you have an answer to those questions?
Yeah.
Or? Okay.
DCIS would be, tamoxifen is the only treatment used for DCIS. The other aromatase inhibitors would be for an invasive breast cancer. So tamoxifen is given regardless of your age if you have DCIS.
Okay. Yeah, this is another. So the comment back there was that aromatase inhibitors are typically not used for DCIS, but that tamoxifen would be used often for DCIS cases regardless of their age. Yes?
There's a group of us who have negative receptor cells, so we're not eligible for anything. And my information is that up to 10 years, I was at higher risk, but after that point, I progressively get to a lower risk, which is so ironic when you think about it. There's nothing in that first few years to guard against a recurrence. Were any of those people in your studies or your stats?
Folks with receptor-negative cancers, yeah, unfortunately we don't have great data on the receptor status of these cancers, and part of that is because back in the 90s and early 2000s that often wasn't assessed for DCIS cases. Yeah, and that's certainly a group of high interest to researchers, is to try to look at patterns amongst those types of cases and work towards having more treatment options available. Yes?
Why would you use tamoxifen for a mastectomy, or one-sided?
Yeah, there the rationale is to lower the risk of an event in the opposite breast. So tamoxifen can work in systematic ways that could, if you feel like you've had this initial diagnosis and you're at increased risk of a second event happening in the opposite breast, then you might consider tamoxifen to lower that risk. Okay, so DCIS, based on those numbers, is reasonably well controlled with those current treatments. Clearly, there are women who go on to still have invasive diagnoses for whom these treatments are not sufficient. But for the, thinking about a 5% recurrence risk, certainly much better than after an invasive diagnosis. But at any rate, surgery, radiation, and hormone therapy, these treatments that are used to achieve these reasonably good control and recurrence rates do have substantial side effects that we would rather not expose all women to if we don't need to. So the question is, can we identify cases of DCIS that don't need such aggressive treatment? And there's really a lot of interest in this right now. And right here I'll review kind of where we are in the research field about what we know, and then talk a little bit about what folks are up to try to improve this. So I'll start with kind of characteristics of the DCIS cancers themselves. And this includes things like estrogen receptor status, tumor grade, and the histological subtype of the DCIS. And here I'm presenting data from a couple of papers from a couple of years ago that really looked at a large number of studies that have tried to address these issues, and then combined all those studies together to give kind of our best estimates of how well these factors predict recurrence. This is kind of an example of some of the results that they come up with. Each of these lines is a different study that has looked at the grade of a DCIS diagnosis. So DCIS is typically categorized as low, intermediate, or high grade. And folks have looked at the recurrence rate amongst DCIS cases with high grade versus low grade. And this plot this shows kind of the relative risk of having a diagnosis. So the first one, you may not be able to read, it says 1.62. So that means women with high grade DCIS in this study were 1.6 times more likely to have a recurrence than women with a low-grade DCIS. Yes?
I have to ask, the word grade is there. What is stage?
Stage reflects where the cancer is in the body and whether it has spread. So it kind of starts at in situ, where it's still in the breast ducts, localized, where it's spread out of the ducts but it's still in the breast, and then regional, where it's into the lymph nodes or other regional areas, and distant, where it's spread somewhere far in the body, like into bones or another location. And then grade is really just looking at the cells themselves and assessing how abnormal they look. So low grade is kind of like, well, these cells look, kind of normal-ish, but there's something wrong with them. And then high grade is, ooh, these, look kind of nasty, like their nucleus is full of extra chromosomes, and they really don't look right. So.
I'm stage 2.
That would, well, maybe I shouldn't get into, I'm not a clinician, so I don't want to even attempt to answer too many personalized. So stage kind of has nothing to do with grade. Like you could have cancers where the cells look very nasty, but it's still confined in the ducts, like DCIS. Or you could have DCIS where those cells actually don't look that irregular. They're kind of just beginning to look malignant. I hope that helps, and maybe we can talk later. So this plot shows, so this one is 1.62, and then the next one's 1.36, and they kind of line up all these studies and then try to combine them together and come up with a kind of summary estimate when they combine all the studies together. And here they found that women with high-grade DCIS were 1.8 times more likely to have a recurrence than women with low-grade DCIS. So almost twice as likely. Similarly, they do the same approach to look at things like surgical margins. So if women had breast-conserving surgery, whether or not those initial margins when they took out the cancer are positive or negative. So that means when they removed the cancer, did it appear that they really got it all, or was there evidence that the lumpectomy took out some cancer tissue but not all of the cancer tissue? And when they compare those groups, it's again about 1.8 relative risk. Similarly for mode of detection, so there are studies on was your DCIS detected by a screening mammogram? So that would be about 85% of DCIS cases, but there's also about 15% who actually do have clinical symptoms, and their DCIS diagnosis rises due to clinical workup. And it's found that if you do have these clinical symptoms, your risk is about 1.7 times as high for having a recurrence as those who were diagnosed by screening mammography. Chemotonecrosis is kind of a histological measure of the DCIS, so looking at how those DCIS cells are arranged. And this necrosis refers to when it's kind of like a ball of cells where the inside of the ball is, the cells are kind of dying on the inside, and it makes kind of like a hole in the middle. And it's thought that this is because the ball is kind of growing rapidly where the inside can no longer get the blood supply it needs to continue growing. So that's been kind of seen as a bad sign, and women with those diagnoses have a 1.5 times increased risk of having a recurrence occurring. And then, so those are kind of ones that folks are reasonably satisfied and feeling like there's consistent evidence suggesting that those increase the risk of recurrence. There's factors that are really common things that we think about, like tumor size and estrogen receptor or HER2 receptor. And actually the evidence on these is rather inconsistent, and there's not really a consensus on how risk of recurrence varies according to these factors. We would think larger tumor size doesn't sound good, and we know estrogen receptor negative invasive breast cancers typically have a worse prognosis. But when we look at DCIS, the evidence is really mixed on this, and there's not any clear pattern in the results. Folks have also focused a lot on patient factors, things like the age of the patient at diagnosis, and there's pretty consistent evidence that women diagnosed at a younger age are at a higher risk of a recurrence occurring than those at a later age. That relative risk is about 2 when you compare women less than 50 to over 50. Folks have also looked at things like menopausal status at the time of diagnosis, women's reproductive history, so things like age at first birth or number of children, and then prior use of hormone replacement therapy. And all of these, again, have rather inconsistent evidence in the literature regarding their relationship with risk of recurrence. So those are kind of the things that the researchers feel like they know. And really, it's rather limited information and of limited kind of use in clinical settings. Because when you think about this relative risk of 2, and really the thing we're worried about is a new invasive diagnosis occurring as a recurrence. So having a relative risk of 2 might be the difference between saying you have a 2% chance of an invasive recurrence or a 4% chance of an invasive recurrence. And that's some information, but on the absolute scale of things, it's typically not enough information to really guide your treatment decisions to say, oh, well, it's only 2%? Okay, I won't do that radiation. But the difference between 2 and 4% is not a whole lot. So there's really, and the other limitation is that's kind of those are the best stratification groups that we have. So that, like I was saying, comparing high grade versus low grade. But on the other hand, you have the vast majority of cases that are in this intermediate grade, which are somewhere in the middle. And really, we don't have a lot of, that doesn't put you on one end of the spectrum or the other. You're kind of in there at the average risk group. And the same for being diagnosed at screening mammography. The vast majority are diagnosed with screening mammography. Most have non-comedo histology, and most cases are over age 50. So if you fall into some of these most common groups, there's just not a lot of factors we know about that can put you into really low risk or really high risk groups.
Do you look at family history as far as your DCIS diagnosis? Because I know my grandmother, my mother, my 2 sisters, and myself are all breast cancer survivors. Mm-hmm. And we all kind of were in different ranges as far as ages and stuff like that. But I mean, I was the only one diagnosed with DCIS from mammo, and I ended up choosing to do a double mastectomy and reconstructive surgery because of my family history.
Yeah.
Do they look at that?
Right. Yeah, that actually has fallen into kind of this inconsistent evidence. I mean, we know just in general, even before a DCIS diagnosis, if you have a family history, and especially an extended family history of breast cancer, that you're at higher risk of developing breast cancer in general. When we focus on DCIS cases and look at family history and risk of recurrence after that DCIS, folks aren't seeing consistent evidence for a relationship. It doesn't really rule out the possibility that it's there. To do these studies, you need to have enough women who with that family history to see that relationship, but it hasn't jumped out of the studies that have been done on this topic. So now I want to kind of talk about some things that are just coming out now, and then some research studies that are planned. I don't know if folks in here are familiar with Oncotype DX, but this has really made a big impact, particularly in the world of invasive breast cancer over the past few years. So Oncotype DX is a gene expression profiling approach that's used for early stage invasive breast cancers, or at least is most useful for early stage invasive breast cancers. And it's able to generate a recurrence score that predicts whether a recurrence will occur in 10 years after that invasive breast cancer diagnosis. And it's often used clinically now to determine whether chemotherapy should be used for the patient. So if the patient has a high recurrence score, chemotherapy might be recommended. If the patient has a very low recurrence score, chemotherapy may not be recommended. And so this came out a few years ago, and it was found, unfortunately, that it was not actually predictive of recurrence after a DCIS diagnosis, which is a little bit surprising and interesting academically, but doesn't help folks with DCIS. However, just this May of 2013, a variation on this Oncotype DX platform was published called the Oncotype DX DCIS score. So whereas the full Oncotype DX profiles a large number of genes, I forget the count, investigators found that if you could focus on a subset of genes included in this Oncotype DX platform, and that looking at the expression of those genes would predict which DCIS cases were most likely to have a recurrence. This was a study that focused just on women treated with lumpectomy only, so just breast-conserving surgery without radiation. And the idea, and there's a lot of interest now in using this DCIS score to guide the decision of whether radiation or tamoxifen should be used in addition to breast-conserving surgery for women with DCIS. And so this just came out recently, and it's still kind of unclear to me how much it's being adopted or how much interest there actually is in using it in clinical practice, but it's for us researchers, at least, to study these things, it's been kind of an exciting breakthrough in the prediction of DCIS recurrence. This is one of the figures from the paper that came out showing the risk of the 10-year probability of an ipsilateral breast event. So this is a diagnosis in the same breast as the DCIS was diagnosed in. This is the DCIS score. So this Oncotype DX kind of spits out a number from 0 to 100 based on the expression of the genes that are evaluated. And this line shows the risk of recurrence according to the DCIS score. So women down here with a low score had about a 10-year risk after 10 years. Women with very high scores had up to about a 30% risk after 10 years. So this is really starting to show some discrimination, between rather lower risk groups and rather higher risk groups. So that kind of is starting to get to where we want to be going, I think, in DCIS risk prediction. A study that we're involved in here at the University of Vermont is called PROSPER. Stands for Population-Based Research Optimizing Screening Through Personalized Regimens. This was a grant that was awarded to UVM a couple of years ago now, and we're kind of in the midst of a 5-year project that's really focusing on DCIS. It's through the Vermont Breast Cancer Surveillance System. And the idea is to improve breast cancer screening by identifying new prognostic markers for DCIS that could help develop more personalized treatments. So similar to the DCIS score, trying to come up with new features of DCIS that could be used to predict which cases are more likely to have recurrence and which ones need aggressive treatment versus those who might be able to be spared aggressive treatments. And some of the things we're looking at include both molecular and genetic alterations in the DCIS cells. So this would be similar to that Oncotype DX approach, is to really study the DCIS cells and see if there's additional chromosomal abnormalities or different morphologies of how the DCIS cells are shaped that predict which cases go on to have a recurrence. Another component is looking not at the cells themselves, but at the area that surrounds the DCIS lesion. So particularly with in situ breast cancer, where the malignant cells are confined within the breast duct, maybe it's not so important what the DCIS cells look like, but maybe it's more important what the surrounding tissue looks like or what's going on in that surrounding tissue that may either allow invasion to occur or prevent the spread of DCIS from occurring. So we're focusing on things like the collagen alignment in the tumor microenvironment, and some other features of this kind of stromal tissue that surrounds the DCIS, which is kind of a new way of looking at kind of DCIS progression because everyone's been so focused on the cancer cells themselves. Another feature is breast density. If folks are familiar with mammographic breast density, it kind of refers to the appearance of the breast tissue on a mammogram. And we know that this is predictive of patients' risk of going on to develop breast cancer at a later date. So women with more dense breasts are at higher risk for developing breast cancer. So we're interested in looking at breast density in the area of the DCIS lesion and figuring out if that has any predictive ability to say which cases are likely to go on to have a recurrence. So we're kind of using some new techniques at UVM to be able to measure density in the kind of precise locations where the DCIS occurred. Another topic I wanted to touch on is another area that I've been involved in and is starting to grow here at the University of Vermont through something called the Vermont Center for Behaviors and Health. So this is a new grant that was just established here at the University of Vermont led by Steve Higgins. And it kind of builds off some of the prior work that we've done in DCIS looking at lifestyle factors in relation to risk of recurrence. And so I wanted to summarize a little bit of that. And the idea of this was, okay, women have been diagnosed with DCIS and they have these treatment options, and maybe we have some prognostic factors that can say which ones are at higher risk or lower risk. But are there things that women with DCIS can do to lower their risk of a recurrence occurring? So is there information we can provide on things that the patient can actually do? And these kind of, we looked really at things that aren't that surprising, but the usual things you hear, like body weight, alcohol, and physical inactivity. We know these things are associated with things like estrogen levels and an increased risk of developing breast cancer in the first place. And there's been a number of studies that have shown that body weight and physical inactivity are linked to disease progression after an invasive breast cancer diagnosis. So we wanted to extend this to DCIS and say, you know, do these factors, do these lifestyle factors appear to influence the risk of progression after DCIS? So this was another analysis that was done in that group of Wisconsin women with DCIS. We looked at body weight and found that amongst premenopausal women, there was no association between body weight and risk of recurrence. However, we found that among postmenopausal women, those that were obese were 40% more likely to have a second diagnosis compared to women maintaining a healthy BMI. And this plot kind of shows this results in another way. This was normal weight women, overweight and obese, and their risk of recurrence at 5 years. And you can see the magnitude of the difference is not dramatic, to put it one way. So obese women had an elevated risk of a recurrence occurring, but it was not a huge difference compared to normal and overweight women. This was just postmenopausal women only in this slide. Physical activity in our study was not associated with the risk of recurrence after adjusting for body weight. And this is what we found. I want to kind of point out the limitations and challenges in studying physical activity in relation to risk. So these results are based on questions that ask women kind of rather simply about their physical activity and focus really on recreational physical activity, and just get an estimate of how many hours per week are you average doing exercise. And we know that there's just so many features about physical activity that we're not capturing in that kind of basic question, like how intense is your activity, how frequently are you exercise? Are you walking for 30 minutes a day, or are you doing something really intense for 2 hours, but just once a week or something? And so trying to distinguish those kinds of differences that may, those kind of things may allow us to zero in better on physical activity. So I don't want to give up on that lifestyle factor in terms of women with DCIS, but our study didn't see any association. However, alcohol, we did see an interesting finding. Women who averaged 1 or more drink per day were twice as likely to have recurrence as women who did not drink alcohol. This shows a graph of the risk of recurrence at 5 years, ranging from below 5% for women who abstained from drinking alcohol. And here is 1 drink per week, 2 to 6 per week, and 7 or more per week. So that's more than 1 a day on average. And you can see this was a bit more of a substantial difference in the risk of recurrence at 5 years. Another topic that we're trying to build off of in this Vermont Center for Behaviors and Health is to look at not only breast cancer recurrence rates amongst women with DCIS, but other causes of morbidity and mortality amongst women with DCIS. And it's actually rather interesting. Women with DCIS are actually more likely to die from something other than breast cancer, which makes sense when you step back and think about kind of the general trends in the population, but is not really something in the forefront of your mind when you've been diagnosed with DCIS, to put it mildly. But this graph is from a study from a number of years ago, but illustrates the general point. This is, depending on what age the woman was diagnosed at, 40s, 50s, 60s, or 70 and older, and her risk of dying during the 8 years following diagnosis according to the cause of death. The blue line is the breast cancer deaths, red is cardiovascular disease, and green is other causes of death. So you can see, say, for women in their 50s, there's a 2% chance of dying from breast cancer, 2% from cardiovascular disease, and 6% from other causes of death. And for the older groups, there's kind of more substantial differences where breast cancer is the cause of death much more or less frequently than cardiovascular disease or other causes of death. And we've seen, like in that Wisconsin cohort study, that we often see adverse changes in a number of kind of health-related behaviors after a DCIS diagnosis. So women diagnosed with DCIS are more likely to gain weight, are more likely to reduce their physical activity levels, are also experiencing psychological anxiety related to their diagnosis. And these are just kind of some general things. There's a lot more specific side effects of the treatments that lead to some of these things. But some of these adverse changes probably increase the risk of things like cardiovascular disease that are actually more common causes of death among these women with DCIS. So we're really interested in looking at these other outcomes amongst DCIS survivors and examining the role of health-related behaviors like weight gain, physical activity, and alcohol in influencing the risk of non-breast cancer outcomes to again try to put things in perspective and provide some more information to patients diagnosed with DCIS about kind of optimal behaviors and statistics and data that can provide them with some guidance on what are the most likely outcomes and what they can do to increase their quality of life and life expectancy. So this is a study that I'm undertaking with Susan Lukoski. She's the co-chair of this breast cancer conference, and she'll be talking, I know, at lunch today about some of these, not specific to DCIS, but more generally cardiovascular health in relation to breast cancer. So I encourage you to check out that talk if you can. So just to summarize, about 10% of women with DCIS will experience a second breast cancer diagnosis within 10 years. About half of these are invasive cancers. Treatments, including surgery, radiation, and hormone therapy, can lower this risk. There are some things that women can do that may lower their risk of a recurrence after DCIS, including maintaining a healthy body weight and avoiding excessive alcohol use. Currently, it is difficult to predict which women with DCIS are at high or low risk for a recurrence. As I mentioned, this is an active area of research, and the Oncotype DX DCIS score is kind of a promising development, and hopefully we'll see a lot more improvement in this area. I'd like to acknowledge my co-investigators, especially Vicki McLaughlin, who is here today. She's done a lot of work doing the statistical analyses amongst the Wisconsin data set, but also other investigators here at UVM and at the University of Wisconsin, and thank our funding supporters. Thanks so much. I think we may have time for one question. I think we have 1.5 minutes. Yes.
The relationship between breast cysts and DCIS, I had both the symptoms.
Yeah, so I guess folks have looked kind of more generally at benign breast disease and found that it is known to slightly increase risk of developing breast cancer in the future, but I've not seen anything focusing on that for DCIS cases in particular. Thanks, everyone.